Good evening, everyone. Thank you for joining us tonight. I'm very excited to announce the start of a new series that Georgetown University Hospital Department of Neurology has put together, specifically focused on our MS patients. And this series is aptly named Knowledge is Power, and that's exactly what it means. We hope that this series of lectures gives you more information about multiple sclerosis, what multiple sclerosis is, so the broad picture, but also some of the more finer details that go into MS care, so symptoms and deficits that we typically see in our clinics. So the goals of the series, again, it's a deeper dive into multiple sclerosis. We will cover topics such as clinical courses that we see in multiple sclerosis, some of the clinical symptoms that we typically see in the deficits, and also how to manage and treat these deficits, and as well as the more psychosocial issues that are involved in our patient populations. So things like depression, anxiety, how to maneuver the process in applying for a disability, how to get power medical equipment. These are all things that actually are very important and sometimes underlooked in many of the discussions that we have in MS care. And so we hope to give you a deeper dive into those specific topics. So the schedule of lectures, we hope to have one lecture out per month. Maybe we could do it more frequently depending on how things go, but at least at minimum one lecture per month. Each lecture we hope to do over 30 to 45 minutes. Now these lectures will be pre-recorded. The last 10 to 15 minutes or maybe even 20 minutes will be a live question and answer session. So we hope patients ask questions and we're able to answer them in live time. And then once these lectures are recorded, we can go ahead and house these lectures on our website, which is posted. And so if, let's say you missed the webinar when it was happening, you can always go back and watch it. Of course, everything that we're doing right now will be free of cost. So we hope that as many people attend as possible and again, gain some knowledge. So our sponsor, our generous sponsor, is Biogen. They've been very supportive of our programs in the past, and they continue to be supportive. So we're very, very thankful for their ongoing support and generosity. So thank you, Biogen. The other folks we would like to extend our gratitude to, obviously the MS providers at Georgetown University Hospital. They're going to be giving most of these lectures. We also want to invite guest speakers, so we're thanking them. The MS Society for their ongoing support and generosity. And then I think Dr. Edwin Serrano. So people who come to Georgetown may meet him very soon. He will be our fellow, our MS fellow from 2020 to 2021. So you might actually see him in person. Dr. Serrano is wonderful. He's a wonderful provider, and he's actually been instrumental in setting this up in terms of AV support, because I certainly don't know what I'm doing on that end. So thank you, Dr. Serrano. Okay. So again, so this first lecture will be a broad overview of MS. So it's almost like the forest view, not just the trees. So what is the immune system? And the reason I think this is very important before we get into MS is you need to understand the basics of any topic before you begin to understand the more complexities that come along later on. So what is the immune system? Very simply put, the immune system is your defense system. It's how the body defends itself from outside threats. And it's made up of many components, cells, tissues, and organs. We will probably focus more on the cells that are involved in the immune system. So this picture is actually showing you the different components of the immune system. The cells in the top right, we're going to get into more detail in just a little bit, but some of the organs that are involved, so your respiratory system, your GI system. Actually, the majority of your immune system is housed in the GI tract. And so again, this is delving more into the current research that's going on in terms of the gut microbiome. The bacterial population that makes up your GI system actually has a very intimate relationship with the immune system and how it functions. And so a lot of research is actually going on with the GI system, the bacteria in the GI system, and how that can lead to autoimmune disease. And the same goes for the respiratory system. This is probably why smoking actually increases the risk of MS, because a lot of your immune system actually is housed in your lungs and the linings of the lungs. Other organs, the spleen, the lymph nodes, the skin. It's actually the largest organ in the body, but again, very important in defending you from outside invaders. So these are the immune cells, okay? Before I go any further, let me give you an analogy. The immune system is actually very similar to the military. And the main function of the military, no matter what country's military you're talking about, but the core function of the military is to protect the borders of the country, right? To protect the citizens of that country from any outside threat. And that's exactly what the immune system is doing. It's protecting you from outside invaders, such as bacteria, viruses, fungal infections. But interestingly, the immune system also protects you from yourself. Now, what do I mean by that? The immune system keeps abnormal cells in check. Okay? It's actually when the immune system fails that people develop malignancy, tumors, or cancer, right? Because all a tumor is rapidly abnormal dividing cells that are normally present, but they're dividing rapidly and abnormally. And it's when the immune system fails to keep those cells in check that people can develop cancer. Go back one. So these are the different immune cells. And again, if you keep the analogy of the military in mind, you could think of the immune system as the military. And just like any military, it's very hierarchical, right? So you have different levels, different classes within the military. At the top, you might have admirals and generals, and these guys are really, or people are really in charge of making decisions. They're making the plans and the decisions, and ultimately what the military is going to do. And underneath, you might have levels that are basically just taking orders, so maybe like the infantry. The immune cells are very much like that. There are certain cells that we think are more in command than other cells. These cells are all equally important in terms of how the immune system behaves, but there's some cells that we tend to focus on a little more in the MS world. So these would be the T cells and your B cells. Think of these guys as your generals and admirals, okay? And a lot of the therapies that we have for multiple sclerosis are now really focusing on B cells and become very important. But again, just keep that analogy of the military in mind in defending the country or defending your body. Okay, next. So what is autoimmunity, right? So we've already defined what the immune system is. Now we have to define what an autoimmune disease is. And so if we break the term down, all that means is immunity to self, auto meaning self, okay? So all an autoimmune disease is an abnormal immune response to a functioning body part. So again, going back to the analogy of the immune system being like the military, let's say the military, certain members of the military begin to go rogue. They go against the orders of the higher ups. And instead of defending the civilian population, they begin attacking the civilian population. Autoimmune disease is very similar to that analogy, right? There's certain immune cells that begin to misbehave. Rather than defending the body, they start attacking different components of the body. And so certain examples of autoimmune diseases would be things like rheumatoid arthritis. Here, the immune cells go after different joints, and that's why people end up with swollen, painful joints. Other examples would be things like eczema or psoriasis. Here, the immune cells are going after the skin. And then there are other examples, such as sarcoidosis, celiac disease. This is where people can't metabolize or can't digest gluten. And there are many other autoimmune diseases out there, but the idea is the same. So the reason MS, I think, stands out as an autoimmune disease is that the immune cells here are going after two very sacred organs, the brain and the spinal cord. And I'm calling these the sacred organs because these really make up who you are as a human being, especially the brain. The brain really sets us apart from the rest of the animal kingdom. The brain makes up your decision making. It makes up your intelligence, your emotions, your personality, essentially the essence of who you are. And then the spinal cord, which comes off the brain, is in charge of more basic functions in life. So for instance, walking, using your arms, reaching out for something, going to the bathroom. So very basic functions of life. They're both important and again, sacred organs that the immune system goes after and leads to MS. So now let's take a deeper dive into MS pathophysiology. What is it that's actually leading to disease in multiple sclerosis? And remember, keep the immune system analogous to the military. So what this slide is basically showing is the top half. So if you divide the slide with the pink line that they're showing there, the top half is what you would see if you were to take the brain and spinal cord, take a section of it, and look at it under the microscope. Okay? The bottom half is basically everything else in your body. Because remember, the brain and the spinal cord are sacred organs. They are separated by a wall from everything else. This includes your blood, your organs, your other tissues. Everything else is separated by this wall that we call the blood-brain barrier. And that's what the pink line is trying to show you. So what happens in multiple sclerosis is your immune cells, so again, some of these cells that they're trying to show, the green circles, they begin to access the central nervous system, but once they have access to the central nervous system, they begin to misbehave. And rather than protecting the central nervous system, they begin to attack it. Specifically, what they're attacking is the myelin, and the myelin here is shown by the gray circles encircling the yellow line. Okay, this is very analogous to copper wires. Every copper wire works because you have rubber coating around it. And the reason you have rubber coating around that copper wire is to keep the electrical impulse from short-circuiting. Because if it starts short-circuiting, whatever you're trying to use isn't going to work. And the immune cells, what they first eat away at is the myelin, is that rubber coating around the copper wire. They sort of begin eating away at it using inflammation. Okay? And this is why we have the symptoms that we do in multiple sclerosis. That once that rubber coating or the myelin is damaged, the electrical impulse isn't being conducted as smoothly as it would if it still had the rubber coating or the myelin intact. And so the electrical impulse begins to short circuit. And once it short circuits, that's what leads to symptoms. That's what you feel. That's why people have optic neuritis, where they begin to lose vision. Or maybe they have numbness and tingling on one side of their body. Or maybe they have trouble using their legs because they're too weak. It's all the same concept. It's short-circuiting of that electrical impulse because the myelin is being eaten away, or the rubber coating is being eaten away. What we're trying to prevent in multiple sclerosis, really what the disease-modifying therapies are trying to prevent, is we don't want the inflammation to get so severe that you begin to cut the axon or the copper wire itself. Right? Because once you start doing that, the damage that's done becomes a little harder to reverse. Again, going back to the analogy of the copper wire, if you damage the rubber, you can put duct tape around it and you can still use that appliance. But if you actually start to cut into the copper wire itself, that becomes much more difficult to do, and most likely you're going to need to throw that wire away. And that's exactly what's happening in multiple sclerosis. Again, this is a more magnified view of everything I just discussed. The top neuron that they're trying to show looks normal. The light blue is the covering or the rubber that is around the copper wire or the axon. It looks nice and healthy, which means that the electrical impulses can be conducted very smoothly, which means everything is working well. The bottom half is showing what happens in MS when those immune cells come in and they begin to eat away at the rubber, which is, again, the myelin, which is in the light blue. And when they begin to eat away at it, you begin to have short-circuiting of the electrical impulse, which then leads to symptoms. And again, if the inflammation or if the damage is severe enough, you actually begin to cut the axon or the copper wire, which is represented by the dark blue. So I hope that makes sense. Now, who develops MS? The short answer is anyone can develop MS. When I was actually in medical school, I distinctly remember being told that it's always young Caucasian women who develop MS. And so when I started my neurology residency and I started spending time in the MS clinic, I was a little surprised by the number of African Americans, Hispanics, and Asians, South Asians, and even people from the Middle East, such as from Iran, were coming in with this diagnosis of MS. It actually astonished me. But the teaching has always been that, like any other autoimmune disease, it tends to affect women much more than men. And the classic age group would be anywhere between 20 to 50. That doesn't mean that, let's say, if you're 60 or 65, you can't come in with a new diagnosis of MS. It actually happens more often than you would think. We have, like I just said, we have plenty of patients in this area who are African American who come in with MS. I certainly have quite a few people who are from South Asia and the Middle East who have multiple sclerosis. So the bottom line is anyone can be diagnosed with MS, unfortunately. Now, people always ask me if it tends to run in families or if it's genetic. There probably is a genetic component, but it's not like we can point to one gene and say, okay, well, if this gene is abnormal, you're going to get MS, or this is your likelihood of getting MS. It's not that clear just yet. We have identified many, many variants of certain genes that if these variants are found, may increase your risk of MS. And so this is why if you have a first-degree relative, there's about a 2 to 4% chance of you developing MS. And obviously, if you have an identical twin, then the chances go up 30 to 50%, so much, much higher. But again, there's really no clear genetic cause for multiple sclerosis. In fact, we still don't know what the cause is. Could it be something in the environment, such as being too far away from the equator and maybe having too little vitamin D? Or maybe there's some viral infection, such as the EBV virus. But again, none of these causes have been identified as the sole cause of MS. My guess is that it's everything. It's environmental, could be even dietary, could be genetic, and it's all of those causes coming together in that one person, almost like a perfect storm, that tips them over to developing multiple sclerosis. Again, just what I alluded to. We don't really know what the cause is. Could it be the Epstein-Barr virus, which leads to mononucleosis? Again, most of the population in the world has been exposed to Epstein-Barr, but not everyone develops MS or any other autoimmune disease. Could it be farther away from the equator? Again, Northern Europeans tend to have multiple sclerosis more than people who live closer to the equator. So again, this is why vitamin D deficiency has been thought of as a risk factor for MS. Smoking, we know that smoking actually increases the risk for MS almost by twofold. Obesity, especially childhood obesity, can increase the risk of MS, so we do have evidence for that. And obviously, being a woman, women tend to experience more autoimmune diseases than men. Okay? The second cartoon is essentially repetition about what we just went over in terms of the demyelination or the eating away of the myelin. And then ultimately, if that is not controlled appropriately, can lead to axonal loss or loss of that copper wire, where things become harder to reverse. And we think that it's this loss of the axon that tends to lead to disability, future disability. Okay, so it's, again, the idea is you want to control the inflammation early so you never get to that stage. You never get to cutting the axons or cutting the copper wire. So let's get more into disease course. Now, relapsing remitting MS is the most common type of MS that we will encounter. About 85% of patients who come in for the first time will be diagnosed with relapsing remitting MS. And so before we get into the course for relapsing remitting MS, we need to define what a relapse is. So a relapse is either new neurological symptoms or even worsening of symptoms that you've had in the past or you may still have at some level, but these symptoms get worse. And they have to get worse for at least 24 hours. So these symptoms have to be persistent for at least 24 hours, if not more. Typically, these symptoms progress over the course of days to even weeks, and sometimes the symptoms can persist for even months. But again, a relapse has to be persistent neurological symptoms for at least 24 hours, and they cannot be explained by anything else. They can't have another trigger. So what do I mean by that? Common triggers that lead to your symptoms getting worse would be typically infection, typically urinary tract infections, having a fever where your body temperature will go up, stress, being very tired, not sleeping. So all of these things can trigger your symptoms, but it doesn't necessarily mean that you're having a legitimate relapse because again, the symptoms or the relapse is being triggered by something else. And I always tell patients that really, you shouldn't have to sit there and figure it out. I think if you are having some symptoms that you are concerned about, you really should let your healthcare provider know. I had a patient come in today who I've been taking care of for quite a few years now, and she's on a very good medication, a very high efficacy medication. And she said, well, 3 weeks ago, I started losing vision in my right eye. And then, it persisted for about 1 to 2 weeks, and now it's kind of coming back. But she didn't call me. And so most likely she had a relapse consisting of optic neuritis. And I should have known about what was going on with her. So I always encourage patients to call their healthcare provider and just talk it over with them. Sometimes the provider may be able to figure it out over the phone, and sometimes they may need to see you in clinic, but it's always better to err on the side of caution. Okay? So common symptoms of MS relapses that we might see, so optic nerve, what I just talked about, optic neuritis, where you have inflammation of the optic nerve supplying your vision. Sometimes if the relapse is occurring in the spinal cord, you might have issues with bowel and bladder continence, sexual dysfunction, difficulty walking, maybe numbness in the legs or the arms. And then there are other symptoms that we typically can see, so things like vertigo or spinning, that spinning sensation like you came off the merry-go-round, being uncoordinated, feeling off balance when you walk, maybe even having a tremor, seeing double. And so this is not the totality of what you might see with MS-related relapses, but this is a good sort of nutshell. Okay. So again, if a patient comes in and they're reporting new symptoms, this is sort of the algorithm that we will typically use. We will ask about those triggers. Do you have an infection? Does it hurt when you urinate, or does it smell foul? That would typically mean that there's a UTI. Do you have a fever? Have you not been sleeping? Are you under a lot of stress? Some of these, so we will typically ask these questions. And if we're not concerned that you're having a legitimate relapse, again, if you don't have an infection that needs to be treated, we may wait 48 hours to see if things get better. And if they don't get better, then we may have to really revisit the idea that you might be having a legitimate relapse. But if you say no to many of our trigger questions, then we really have to assess you to see if you're having a relapse. If it's a relapse or there are certain symptoms that we are overly concerned about, we might want to treat you. If there's certain symptoms that, maybe it's just some numbness and tingling in the hand, that doesn't worry us as much, and we may not jump to treating the relapse. Okay? So treating a relapse, these are the medications we typically use to treat an MS relapse. Most commonly, these are IV steroids. And now, actually, steroids can also be given orally, so people can take them at home rather than being admitted to the hospital. But even with IV steroids, sometimes we are able to set the IV steroids up at home for you to make it a bit easier. Intravenous immunoglobulins is another modality, another therapy we may use. Plasma exchange is more invasive. It's similar to dialysis. You need a catheter that needs to be inserted, and then plasma exchange is usually done over the course of a week, and so we're essentially filtering out the blood to take off all the bad immune cells that are leading to the relapse. And then Acthar gel, or ACTH, which is a type of hormone, is also another option to treat a relapse, especially if you haven't done well with steroids in the past, or maybe you have a contraindication to steroids. Acthar is an option. Okay, so let's go into the MS disease courses. Let's start off with relapsing remitting, like I talked about. So on the y-axis, or the vertical axis, you have disability. On the x-axis, you have time. So as you go up, your disability goes up. As you go this way, time goes by. So let's say I'm a 21-year-old college student and life is wonderful. I have no worries other than graduating. So I'm chugging along, but all of a sudden I wake up one morning and I can't see out of my right eye. Or maybe I feel really dizzy and the dizziness is not going away. So my disability score just went up. So that's the first peak that you see. And like any other college student, I ignore it because I'm young and healthy and I don't think anything can happen to me. So more often than not, my symptoms will get better, maybe not completely better. Maybe I have a little bit of blurriness in the right eye. Or from time to time, I might get dizzy when it gets really hot outside or when I'm stressed out. And so that's why I don't come back to where I started. So I'm left with just a little bit of disability, okay? But I don't seek treatment. And then time goes on, and maybe I have another relapse, but this time, the relapse is more severe. Let's say this time, I start to drag my right leg, and it's interfering with the way I'm walking or ambulating. So the disability score might go up a little higher, and that's what the second peak is showing. Again, as I go up, disability goes up. And then this pattern repeats itself. This is relapsing remitting. You have a relapse, you remit. You have a relapse, you remit. And then this pattern can keep going. But the thing to notice is that as you have these relapses, there's a potential that your overall disability will continue to increase. And that's why the slope is going this way. It's not coming back down to where it started. That is relapsing remitting MS. Okay? Now, this is secondary progressive multiple sclerosis, and ultimately, I'll be honest, this is really what we're trying to prevent with our disease-modifying therapies. So when someone is young, especially when they're young, 20s, 30s, 40s, they typically come in with this relapsing remitting course. But if things aren't controlled very well, the concern is that rather than having those distinct relapses or periods where you have worsening of your neurological symptoms, those relapses tend to go away. Maybe they become less frequent or they become less noticeable. But instead, your disability slowly begins to go up. It's very insidious, it's very slow, okay? So the example I gave last time, a young woman, let's say she's 25 by now, she started having weakness of the right leg, she got somewhat better, maybe she went untreated for several more years. That right leg over time gets heavier and heavier and heavier to the point where she may no longer have use of it. That is secondary progressive MS, we think, okay? This is primary progressive MS. This is rarer. It happens in about 10 to 15% of patients who are diagnosed with MS. And rather than having those very distinct relapses, those distinct peaks and valleys, it's a slow progression from the beginning. So it's like going into secondary progressive MS from the beginning, from the very start. And again, slowly over time, insidiously, the disability score is going up. Okay. Now, let's talk a little bit about MRIs. So MRIs have become very, very important in the MS world. We use them to help us diagnose multiple sclerosis, but then we also track you in terms of how well you're responding to whatever medication you're taking. So this is a normal set of MRIs. This is what your MRIs should look like if you didn't have pathology, if you didn't have MS. The first MRI is the MRI of a brain, and it's basically a top-down or a bird's eye view. So if the brain was split or cut open like this and a bird is looking down, that side is your right side, this side is your left side. And it looks beautiful. It should look gray. Those dark spaces are fluid filled, they should be there. That's normal, okay? But that's a beautiful looking MRI. The spinal cord, as I said, comes off the brain. And it's never as pretty as the brain just because it's a very thin piece of tissue, so it never looks as defined, as nice as the brain does. This is a more magnified view of a spinal cord, and this is your cervical spinal cord. So this is the segment of spinal cord that runs along the neck. And again, that gray cylinder that's coming down, that is your spinal cord. And it's supposed to be surrounded by a sea of white. That's your cerebral spinal fluid or your CSF. And again, it should be nice and gray throughout. So that's what normal MRIs should look like. Okay. What does an MRI look like for a person with multiple sclerosis? So I want you to focus on the bottom two images. The right, this one, that one, and this one, bottom two. And so what the first one is showing you, obviously compared to the normal MRI I showed you, it's not great. It's got splotches of white that should not be there. So those are your MS plaques. Those are areas where those immune cells have come in, they've caused damage through inflammation, and then they've left. But what they've left behind is a scar. It's a sequelae or a consequence of the inflammation that was done. Okay? But I have no idea when those lesions or when those scars developed. It doesn't give me a sense of time. That could have happened 10 years ago, could have happened 3 months ago. But again, most likely all of the lesions happened at separate points in time. I just can't tell you when. However, the image on your right, so this image, it's this person's brain, but again, the thing that you notice is only some of the white spots are showing. Right? And the reason those white spots are showing is this MRI was done after the person was given the gadolinium dye, the dye that's given through the veins. And some of these lesions are actually taking up the dye. And what that means is that they're actively forming. And so what I compare this to is a campfire. So if I walk across a campground and I see a few people having campfires burning, it gives me a sense of time. Those are actively burning in front of me. Eventually, those campfires are going to burn out, and all you're going to have is ash on the ground. So if I walk across the campground the next day and all I see is ash, I don't really know when those particular campfires were burning because all I have is ash and it all looks the same. So If you have actively forming lesions or enhancing lesions after the dye is given, then those lesions are actively forming. Those are actively burning campfires. It gives you a sense of time. The first image are the burned out campfires, the ash on the ground. So it tells you what's happened in the past, but you don't know when it happened in the past. So essentially what I'm getting at is that the dye sometimes can give you an idea of time, which is important when we diagnose people with multiple sclerosis. This is an MRI of spinal cord of someone who has multiple sclerosis, and remember, it should be gray throughout, but in that first image labeled A, you can see there's an arrow that's pointing to a white matter lesion. So exactly what's happening in the brain can also be occurring in the spinal cord, okay? And in C, it's subtle, but what they're trying to show is that this particular lesion is actively forming, and that's why it's taking up the dye. After about 30 days, it's no longer gonna take up the dye, and it's just gonna look like a burned out campfire or like square A. So how do we measure disability progression? And just to rewind a little bit, when it comes to disease-modifying therapies, we're looking at 3 metrics. Every single disease-modifying therapy that's on the market right now went through phase 3 clinical trials. And in those phase 3 clinical trials, the 3 core metrics that they were measuring, did this medication decrease the number of relapses someone is having? Did it decrease or prevent the white matter lesions on MRI? And did it slow down or did it prevent disability progression? So how do we measure disability progression? We measure it using the Kurtzky Expanded Disability Scale. Dr. Kurtzky was actually, he worked at Georgetown. He was an MS expert and quite revolutionary in the field because he came up with this scale. Unfortunately, he passed away a few years ago, but I was lucky enough to meet him at least once. So look at this scale. As we go up, again, on the vertical axis or the y-axis, disability goes up, and this scale really goes from 0 to 10, okay? 0 meaning if I were to examine you and do a very thorough neurological exam, I wouldn't be able to pick up any disability. When you get to around 3 to 4, this is when patients begin to notice that there's something wrong, there's something not quite right that might be disabling them. And then when you get to 6, that's when people need to use at least a cane. So they need assistance at least on one side, whether that's a cane or a crutch. When you get to 6.5, you need assistance on both sides. So whether you need a walker or maybe you need a person to hold on to you with both arms. And then when you get to 7, that's when people are restricted to the wheelchair. And again, the numbers will keep going up, and then 10 being death. So going back to the medications, what we're trying to prevent is, let's say you start off at a 2.5, so you have very minimal disability. If we start you on a medication, we hope to keep you at 2.5. We don't want you to go from 2.5 to 4 because that means that you're accruing disability. Okay? The other thing to notice, the other thing that's shown nicely on this cartoon is at the bottom they're showing you arrows, and what those arrows are indicating is the activity of the MRI. And so what's important to pick up from this is even though, let's say you're at the lower end of the scale, you're from like 0 to 2.5, even though you're not manifesting anything wrong on examination and you're not complaining of disability, the MRI might still be accruing lesions. Okay, and remember those lesions ultimately will catch up to you and might lead to disability progression. Okay? And again, if you keep the concept, what I just showed you, the fact that MRI might actually be accruing lesions even if you feel great, it's very analogous to an iceberg, okay? If everyone watched the movie Titanic, came out many, many years ago, but the reason that Titanic slammed into that iceberg was because they actually couldn't see the iceberg. If they could see the entirety of the iceberg, they would have maneuvered around it. MS is very much like an iceberg. The majority of the disease is actually taking place underneath the water. And maybe a little, the tip of it is showing. So the symptoms or the deficits might be showing. And this is particularly important when people are young because the water is actually quite high when you're young. It's covering most of that iceberg. And so the level of the water or the depth of the water is very similar to, or it's analogous to neurological reserve. The higher the level of water, the more hits you can take without manifesting symptoms, okay? Now, with enough hits, however, as well as aging, the water level begins to decline. And so when that happens, the lesions that are accrued now become more manifest. You actually become symptomatic, and the disability score might start to go up. So one of the important things that we are realizing in the MS world is preserving the neurological reserve, preserving the depth of that water. So even though you might have MS, it's not really impairing you in any way, and the disability score is not going up. Okay. So again, I sort of touched on this already, but the three metrics that we use to figure out whether an agent is effective: does it decrease the number of relapses? Does it prevent changes on the MRI? And the hardest metric would be, does it prevent disability progression over the long run? Okay. So that's the end of the presentation. And so now we're going to go into the question and answer period. So please, please, please ask questions, and we're happy to answer them. But thank you for joining tonight. Hi, everyone. Good evening. This was a broad overview of MS. The lectures that will follow will be a bit more focused. For instance, Dr. Brian Barry, who actually just became one of our faculty members. Some of you may have met him. He was a fellow just recently, but we are very proud to have him as part of the faculty now, and he will be presenting disease-modifying therapies in about a month. So I hope you tune into that. Later on, we have Dr. Edwin Serrano, who introduced the series at the very beginning. He will be presenting race in MS. At some point, we will also be sharing some more information we have about COVID-19 and how it's affecting our MS patients and what we know about it so far. And then again, we will have a whole series of other lectures coming out. For instance, Dr. Osborne will also be focusing on vision and multiple sclerosis. So again, just stay tuned. We hope people attend. Again, this is more for your knowledge. And I will stop chatting and I'll take the questions.
Okay. So the first question that I saw in the comments is in regards of the flu shot. So what are your thoughts on flu shot in patients with current MS?
So it's okay. It is safe. So the guideline with vaccines, which is what the flu shot is you want to avoid vaccines that are live, that contain live virus, because the concern is that it's going to rev up your immune system and it can lead to an MS relapse. So in general, the guideline behind vaccines is it is okay if the vaccine is not live. The flu shot is a not live vaccine, therefore it is safe. And even some of the live ones, they do have their place. For instance, let's say you need to be started on a disease-modifying therapy. Some of the more, the higher efficacy ones, sometimes we do need to make sure that you have immunity to certain viruses. And in most of those cases nowadays, a lot of the vaccines are not live, but even if the vaccine is live, there are certain instances where we do need to administer live vaccines. We just have to be very careful, and then the timing of the vaccine and the initiation of that drug needs to be worked out. But in general, non-live vaccines are safe. So yes, the flu shot is okay to get. In fact, it might be a good idea these days with COVID-19. So if you do get immunized with the flu shot, hopefully we can prevent influenza. And if you do maybe get sick and you need to be tested for COVID-19, it might sort of decrease some of the ambiguity.
Okay. Now, another question is, any diet recommendations in regards of MS and
so that's
inflammation?
a hard question, and I think we will be presenting that topic. Diet in MS is very important. I actually did present this about 2 years ago during our Patient MS Education Day. So if anyone is interested, that video is actually housed on our website. But in general, the idea behind diet is that you want to have a healthy diet. The majority of your diet really should be plant-based, so coming from fruits and vegetables. You want to minimize fats, especially saturated and trans fats. You also want to minimize salt. We know that excessive salt can be pro-inflammatory, so the guideline is usually less than 1.5 grams of salt per day. When it comes to red meat, you want to minimize red meat. And a good source actually of information when it comes to diet, and this is just in general, a healthy diet, would be the American Heart Association's website. They have some very good guidelines that I think are very doable. Certain diets tend to be very extreme. They're hard to stay compliant with. They can be very expensive. And so if you find a diet that is moderate in terms of the amount of carbs and fats that you're consuming, it's probably okay. And again, the majority of your food should be plant-based. And again, I would like you to maybe go to the American Heart Association's website. Our website has a video that I presented at Patient Education Day about 2 years ago. I think those are very good sources of information if you're interested.
Very well. Now, Dee ask, do you have the current numbers of people living with MS that have contracted COVID-19 and have died?
I think those numbers are still coming out. I think this is a work in progress. And don't hold me to this, but I don't believe many people have died who have MS and have contracted COVID-19. For the most part, it seems like patients are making their way through. It is not a death sentence for as far as we can tell right now. I think that, again, the numbers are still being collected. We're trying to figure out whether there's certain medications that may increase the risk of a poor prognosis in a patient with MS. So MS itself doesn't mean that if you get COVID-19 and you have MS that things will end badly. The concern right now comes in with some of the medications that people are on, because again, whenever you start to affect the immune system, one of the main things that we always worry about are infection, and that includes viral infections. But I think right now things are looking good. The numbers and the data is still rolling in, so stay tuned, okay? Stay tuned.
Anonymous, any recommendations to help with weight loss, especially when exercise can be challenging due to pain inflammation? Can medications be prescribed to help jumpstart weight loss?
That's a good question. I think as long as you're ambulatory, right, as long as you're able to use especially your legs, I think that if you can exercise, and it doesn't have to be anything intense, right? It's not like anyone's asking you to run a marathon or do a triathlon, but do something. 30 minutes of low intensity exercise per day is the current guideline. If it's high intensity, you could probably do it every other day or 3 to 4 days a week for 30 minutes, again, high intensity. I think a lot of our patients, what they experience is that they begin to lose the use of their legs. They become less and less ambulatory, and so exercise is not really possible. And it's no fault of theirs. I think one form of exercise that might be very beneficial in this type of patient population would be swimming or getting into the pool, because when you're in the pool, you don't have gravity, right? You're kind of weightless in the pool. You can start moving your legs. And actually the temperature of the pool, if it's warm, may help with patients who have spasticity or muscle tightness. But it is difficult. I think if you are non-ambulatory and maybe the pool is not an option, you really have to pay attention to your diet, your portion size. There are certain medications that help with weight loss, but again, that's some of these medications come with their own risks, especially cardiovascular risks and side effects. And so it needs to be a conversation between you and maybe your MS doctor, your neurologist, and even your primary health care physician. It sort of needs to be a coordinated approach, because some of these diet or weight loss pills can come with their own adverse side effects. Although it is a good question, and I think those pills remain an option, but only if you really cannot exercise. So it's a good question.
Anonymous, what's the biological connection with progressive MS and frequent urination?
So it's not about having progressive MS or relapsing remitting MS. It's what is happening within the brain and the spinal cord, especially the spinal cord. So MS, as I said in the lecture, affects the brain and the spinal cord. Whenever you start to affect either both of those organs or just one of those organs, one of the consequences can be irregular or bladder dysfunction. And typically what we see is an overactive bladder. And so what patients will complain of is when they have this urge to go to the bathroom and urinate or even to defecate, sometimes they can't control that urge. They have to get to the bathroom very quickly, and if they don't, they do have accidents. It's called urge incontinence. So that's typically what we see. It's not a matter of having progressive MS or relapsing remitting MS. It's just because you have lesions in the brain and the spinal cord, the bladder dysfunction and the bowel dysfunction become a consequence of those lesions. And so therefore that specific set of symptoms, the issue with the bowel and bladder, have to be dealt with other medications. Okay, the disease-modifying therapies may not help with that, but that's a good question.
Carrie wants to know, why do women tend to experience more autoimmune issues than men?
It's the blessings of being a woman. No, I'm just joking. Unfortunately, for whatever reason, and I may not be able to answer this question accurately, but women, when it comes to autoimmune disease, our immune systems tend to misbehave. It's just, this is what we see with other autoimmune diseases too. There tends to be a predilection for women. And again, I may not have the entire scientific basis for this, but it probably has something to do with hormones, how our immune system is, how it's built, how it's interacting with other tissues. I think it's a very complicated answer. So, but it is something I should probably look into, and if I can find a better answer, I'll definitely post it.
Anonymous, what's the latest in research around remyelination?
So there's a lot of research around remyelination. Unfortunately, in fact, there is a trial that we're actually participating in, or we're participating in. But I do think that it's a little bit down the road. The immune system is incredibly complex, and the repair mechanisms and the regenerative mechanisms involved in trying to repair the damage that's happened is a very high bar to achieve. And that's why we really haven't had any medications that have hit the market that are really there to repair and not just stop the inflammation, not just prevent the damage from happening, but to reverse and repair the damage that's happened. We're not there yet, unfortunately.
Just a nice comment from Mr. Flanagan. Great information on the slides. Reads so practical. I'm already on track to be well informed. Visual presentation looks fabulous. Keep up the good work.
Oh, thank you, Mr. Flanagan. That's very sweet of you. Thank you.
Even when we had a little
Yeah, we had
problem.
some glitches at the beginning.
Anonymous, if your lesions are only showing up on your brain, what are the possible symptoms of a relapse?
It's a good question. So that is an excellent question, because typically, oftentimes we see relapses, and again, it has to do with the plasticity and the reserve in the brain and the spinal cord. So when we do have lesions that develop in the brain, I would say oftentimes they're silent, although patients sometimes do complain of cognitive fogginess that might be more acute in nature. That could be an indication of a relapse or a lesion that is occurring in the brain. And again, it depends on where in the brain. Some parts of the brain are what we call more eloquent than others. So there's certain parts of the brain that are higher in terms of real estate price than others. So if you hit that part of the brain, you might feel it. So there are parts of the brain that are more primitive, and you would think, well, they're more primitive, they're less important. No, those areas of the brain that we consider more primitive are actually prime real estate. So if you hit those areas of the brain, you're more likely to have symptoms. So for instance, double vision, vertigo, drooping of your face, numbness along your face, even tremors. And the optic nerve, don't forget about the optic nerve. The optic nerve is actually a part of the brain. So when you hit those certain areas in the brain, the more eloquent areas, you're more likely to have symptoms. Whereas other areas that are not so eloquent, you might have a lesion form there, but you may never feel it. It may go unmanifested. You may be asymptomatic. So it's a good question.
Do lesions need to be on your spinal cord to impair walking and movement?
No. So in most cases, the lesions that do develop in the spinal cord do impair walking and movement. But again, there's certain areas in the brain that when affected can also affect your walking and movement. So it's not always the spinal cord, but in the vast majority of cases it is.
Anonymous, currently I am on Tecfidera. I'm wondering if this makes me more vulnerable for contracting COVID-19 and higher chances of complications if I contract the virus.
So Tecfidera is not one of the ones that we consider as being very immunosuppressive, although in a certain subset of patients it can suppress the immune system, but for the vast majority of folks it does not. So Tecfidera is one of the ones that we don't consider to be high risk when it comes to something like COVID-19 in the vast majority of folks, from what we know right now. And again, as I said, the story is an evolution, and the more numbers we get, the more cases that come out, the more we'll be able to inform you about COVID-19 and very specific medications.
How often should one get MRIs?
So you should definitely get an MRI in order to be diagnosed with MS, right? So that's number one. Number two, you should probably get an MRI, again, and this is going to vary, right? But every 6 to 12 months is a good, it's a good number for most folks. And again, the reason we tend to get MRIs at least once a year is to make sure that the medication is working. All right, and sometimes we're also doing it for other issues, for certain medications, very specific medications. There might be more to it than just to make sure that the medication is working. But for the vast majority of folks, obviously we need one in order to definitively diagnose you with MS, and then we'll probably get one every 6 to 12 months for most medications to make sure that the medication is working.
Great. Annette wants to know about a potential cure, thoughts about neuroplasticity, and can the brain be retrained?
So unfortunately, I don't think a cure is, obviously there's not one currently available. A lot of the medications, unfortunately, are very good. The medications are getting better and better in terms of hitting those 3 metrics we talked about in the lecture. But we haven't found a medication that's 100%, right? It's not 100% in each of those metrics, unfortunately. And I don't believe we're there yet. I think there's a lot of research going into MS, but not yet. And what was the other question, Evan?
About neuroplasticity and retraining of the brain.
So, in general, there's a medication can only do so much, right? So a lot of this, and this goes back to one of the first questions that was asked, a lot of disease management in MS will come down to lifestyle, right? Are you living healthy? Exercising the brain. Exercise helps with sort of making sure that you maintain that neurological reserve. The same can be said for diet. The same can be said for sleep, obtaining good sleep, trying to manage stress, trying to manage psychological issues, right? Depression, anxiety, panic. All of those things are sort of rolled into one ball of lifestyle choices or a healthy lifestyle, but all of that is important in terms of managing this disease and sort of preventing its progression.
Now, the next question, basically you already answered, but I'm just going to say it to do due process to address everyone's concerns. The question said, besides working with our physicians regularly, what is the number one thing we can do for our health? But that you just already answered that one. Okay. R is asking, how do I know if my relapsing remitting MS developed to secondary MS?
It's a good question. And it's a question that sometimes clinicians will also struggle with, because it's not like one day you have relapsing remitting and the next day you wake up and you have secondary progressive. This happens over time, tends to happen very slowly and insidiously. So if you begin to feel like, I'm slowly getting worse, it's very slow, that may mean that you're entering a more progressive phase of the disease, unfortunately. Your MRI may not change as much, right? The relapses may not occur as frequently, or if they occur, they're not that noticeable. That might indicate that you're entering a more progressive phase of the disease, but it's a very slow sort of process. And so it's sometimes even hard for clinicians to figure out, well, is this person relapsing remitting, or is this person in secondary progressive? And as many of you know, I'm sure, who are watching this, I feel like probably understand this concept more than I'm able to explain, in all honesty.
D wants to know, what advice would you have for people with MS when a vaccine for COVID-19 comes out?
It's a good question. It's a question that I've thought about as well. Obviously, I think one of the basic questions that would need to be answered is if this vaccine is live or not live. I think we're going to have to cross that bridge when we get to it, in all honesty. And it might also come down to the type of medication you're on for the MS, because there are certain medications that might affect how you respond to the vaccine. So again, a lot of these questions are unknown right now. They're all very good questions, but unfortunately, we just don't have the information to answer them as honestly as possible. And again, we will be doing a lecture on COVID-19 in a few months, probably in about 2 or 3 months. So stay tuned. So hopefully we'll research this in much more detail and have a lecture prepared.
Now, what special precautions should MS patients take during COVID-19, especially when shopping, working, or teachers returning to school?
I think it's the precautions we're all taking. Just make sure you have a nice mask. I've noticed that folks are walking around and the mask is down here. It's kind of just covering the mouth, or every time they talk, the mask kind of goes up and down. I think one of the best things you can do for yourself is make sure you have a good mask. I personally like the surgical masks that we wear in the hospital. They're not the N95s, but just a regular surgical mask. You have it fitted nicely around your nose. It's got a nice seal to it. It's covering your mouth. Make sure that you're washing your hands, right? Maybe change your clothes when you come home. Maybe not wear the same set of clothing and the same set of shoes that you're wearing on the outside and bring those germs into your house. Obviously, try to avoid large gatherings of people. The same stuff that we're all being told in the media. I think if you follow that and try to be as careful as possible, you'll probably be okay.
Anonymous, any recommendations to help with sexual dysfunction with MS? And number 2, any recommendations on the InterStim 2 stimulator?
What is the second one?
InterStim 2 stimulator, like the perineal
Like the
there?
bladder? So, sexual dysfunction is different in men and women. Tends to be a little easier to fix in men. Other than the typical drugs we think of, especially for men, I think this question is something that if it is happening to you, whether you're a man or whether you're a woman, I think if you're a woman, it's a conversation you may want to have with your gynecologist, especially as women get older. There are other things that tend to happen to us as we get older that need to be dealt with certain creams and certain other medications. With men, it's typically a discussion you need to have with a urologist. There are other ways to, have an erection aside from just medications. And again, without getting into too much detail, I would prefer that patients have this conversation, honestly, with their urologist or with their gynecologist. But it is an important facet of life, and I think it needs to be addressed maybe more so in clinic than we typically do.
Are there herbal supplements that you recommend or advise MS patients to avoid?
Well, most supplements and vitamins are probably safe. There are certain medications or certain supplements that I feel like sometimes may rev up the immune system a little too much. One of them being echinacea. Try to be careful with that. It's not like you can't take it, but maybe not excessive amounts of it. But most vitamins and supplements, as long as they're taken according to, what is according to guidelines, you're probably okay in terms of vitamins and supplements. Especially the more run-of-the-mill ones like vitamin B12 or vitamin D. Biotin had some traction in the MS world a few years ago. Omega-3 fatty acids are a good thing to start taking. But some of the more obscure ones, again, I don't feel like anyone's going to be able to answer that honestly, just because it's not something we typically study on a large group of people, right? Some of these obscure ones like ashwagandha and I don't know, there's all kinds of new vitamins and supplements out now.
Mhm. Can a speech exercise or loud reading be helpful with speech problems in MS?
That's an excellent question. A lot of our patients, in fact, I saw a woman today whose speech is getting worse and she's getting softer and she's having a harder time swallowing. So one thing to do is, especially if you start having trouble swallowing, or if your speech gets softer and softer, or if you start to develop a weak cough, one thing you may want to bring up with your healthcare provider is getting a speech and swallow evaluation, making sure that your diet is safe, the types of food that you're eating are safe, maybe even getting something called a modified barium swallow. When it comes to actually speaking loudly, this is something we usually see more of in the Parkinson's disease world, where they're actually, they have to be mindful about how loud they are speaking. And I don't think that is any different for maybe patients with MS. You may need to be more mindful about how loud you are speaking, and there's actually speech therapy for that specific issue. So again, speech pathologists would be the people to turn to here.
Anonymous, what helps with numbness in the fingertips?
So sometimes fingertip numbness can be related to MS. Sometimes it could just be related to compression neuropathy, such as carpal tunnel or tennis elbow. So that's one thing that needs to be worked out. Numbness is a hard thing to treat. We do have medications that may help with the numbness or even some burning pain that people experience. So again, certain medications, again, not the disease-modifying therapies, but there are certain symptomatic medications that we'll use that may address the numbness.
Now, this question is kind of thick, so I'm just going to try to dissect it. So this person basically saying that he was newly diagnosed with MS and he started on a DMT right off the bat. His question is, for how long he should be on that DMT if he doesn't have new lesions or attacks?
This is a hard question, and again, this is a question that's trying to be answered in the MS world. What age maybe is it safe for patients to start coming off of disease-modifying therapy? It's a question that's being researched. But in general, we typically maintain patients on medications for a long time, as long as that medication is working. And if that medication stops working, then typically they're changed or switched over to another medication. So it is, once you're diagnosed with MS, most people will be on medication for a very long time. So it's a good question. As long as you're compliant, as long as you're tolerating it well, and as long as it's working, you're going to be on medication.
Mr. Swanson wants to know, are there any special conditions related to lesions on the cervical spinal cord?
So lots of things. I mean, the cervical spine is here, runs along your neck, and it controls everything from here on down. So it could be anything, right? Your arms, your legs, your bowel, bladder, your balance, numbness, tingling. Lots of things could be involved.
Any research in regards of stem cells and MS?
So stem cells are I think, were a hot topic a few years ago. Unfortunately, stem cell transplants are not approved in the FDA, in America at least. There's certain, again, and it depends on the protocol that's being used for the stem cell transplant. Some of the protocols are pretty harsh. You have to remember that once they harvest the stem cells, they basically ablate your bone marrow. That is not a very, that's not a very easy thing to go through. And those therapies that they use to ablate the immune system can have their own very high risks. And then the benefits may not match. So again, these are complicated questions, and sometimes you have to look at that individual person. But for the most part, for most people, it's not something that we typically will recommend in the United States.
Anna, is it on average for a DMT to take 2 years to start working and benefit a patient?
No, most DMTs should start to work fairly quickly. within a few months. Now, how you're doing on those DMTs, how those DMTs are, how effective they are, might take some time, might take up to a year or two. Again, everyone is different, but typically we don't switch people off DMTs after 3 months or 4 months or 5 months. We have to give the DMT time, but it's usually not 2 years worth of time.
Mr. R, if a lesion in the spine can cause movement disability, then why is it rare that doctors prescribe full spine MRIs?
Why is it rare? It's a good question. Even in clinical trials, the spinal cord has been sort of neglected. Typically, and again, every healthcare provider is different, but we typically don't order MRIs of the spinal cord unless we can pick up symptoms or deficits that might be referable to the spinal cord. Usually the action in MS, and again, it's not in every case, but typically the action in MS is usually the brain or the cervical spine. So again, this is my practice. It's not right, it's not wrong, this is just how I do it, but I typically will order a brain and cervical spine. And unless I can pick up something that would be referable to the thoracic, usually we may not image it, okay? So it depends on what you're coming in with, the exam findings. That will help guide us to figure out whether we really do need to get MRIs of the entire spine, or maybe a part of the spinal cord, or if any of the spinal cord, okay? But the brain is usually the organ that is focused on the most in terms of disease activity.
Can I eat something to help with myelin reproduction?
For myelin repair? So I kind of answered this already. Again, going back to lifestyle, disease-modifying therapy, all of that is going to be important in how well or how you basically manage this disease, and maybe even in terms of healing.
Is there any medication that helps with brain fog from MS?
I mean, there are certain medications that help, that we consider more stimulant in their effect. One thing that I think first needs to be addressed with brain fog is your level of fatigue, how well you're sleeping. There are certain medications, and again, I don't want to talk about specific medications for this, but there are medications that can help with fatigue, and by helping with the fatigue, you can help with the brain fog. Okay, and then there are other medications that are just there for pure brain fog, to help with attention, right? To help with mental processing speed. Again, those are also usually the stimulants. So yes, there are.
Can you retrain your brain to increase cognitive functions?
To increase everything we just talked about, right? Making sure, and again, a part of this is also making sure that your brain remains active. So reading, writing, listening to music, trying to keep that brain active. It's like a muscle. If you don't use it, it's not gonna work as well. And that goes for any person, not just for people with MS.
Is there any age after which a patient whose MS have been stable for several years can safely stop taking DMTs?
So again, this goes back to, I think, one of the other questions that was asked. This is a question that is being looked at. It's unanswered right now. And again, clinicians have the same question, and that's one of the reasons why it's being researched right now. So right now, it's not like I could say, you're 55, I can take you off medication. It doesn't work that way. It depends on your history, your risk factors, the risks of the medications, and that is a very individual discussion.
Okay. So that was the last question. Thank you also for the beautiful comments from everyone. We have done this, and we're doing this for you. Okay?
Bye, everyone. Thank you, and enjoy the debate tonight.